Hi, we're Group 10, aka Engineering Better Medicines. Our project takes on the idea of using our own genetic information to diagnose more effective medications for patients suffering from mental health issues. Today, we're going to take you through our research and even a mock bill that we made as a proposal to establish guidelines for more of this testing.
Our chosen grand engineering challenge was to engineer better medicines. But what does this mean exactly? Our challenge covers a vast expanse of topics, including but not limited to the personalization of medicine, vaccinology, and metabolomics. Our approach was to tackle personalized medicine in mental illness. How can we use the genetic information in our own bodies to tailor a more effective medication for serious mental disorders?
About 386,000 adults suffer from serious mental health issues in North Carolina, including schizophrenia, bipolar disorder, and major depression, and only about 50% receive some form of treatment. As a state, North Carolina ranks 33 out of 50 for providing access to mental health services. As you can see on the map, a large portion of North Carolinians suffer from some form of mental illness.
In our project, we seek to combat the mental health crisis by utilizing pharmacogenomics. This will help provide easy access to genetic testing that can be used to prescribe medications for patients. Genetic testing can empirically prove which medications would be most likely to help treat the patients. In the Research Triangle area of North Carolina, there are many labs working on progressing the field of pharmacogenomics. For example, the Tim Wiltshire Lab, the NC Precision Health Collaborative, and the Patient Advocacy Initiative.
One of the main problems with current drug therapy is not knowing whether the specific drug will work well in a patient. It takes around 6 to 8 weeks of trying each medication before it can be confirmed how the drug is working. When patients have to try multiple medications, it takes a very long time before they may start seeing the results they want. Without genetic testing, physicians are prescribing medications based on their own personal preference. They may not have any concrete reason to choose one over another, and it's almost like a guess and check. Here's a list of medications we looked at that have biomarkers for mental disorders. These are medications we could genetically test for.
You may have never heard of pharmacogenomics, and there's a pretty good reason why. It's an extremely complex field with a lot of research being done around it. So why is it important? Pharmacogenomics involves the study of human genes and how they affect responses to medication. Knowing this allows pharmacists to alter the medications, not the genes, to better suit the patient. The overall goal of pharmacogenomics is to use clinical and genetic information to better target specific drugs and doses to patients. In current pharmaceutical practices, more than 50% of individuals may get poor drug responses, resulting in ineffective drug therapy. 10% of all healthcare costs are related to these adverse drug reactions, making them a highly expensive form of therapy. About 18% of all patients today are known to be affected by pharmacogenomics.
There are currently 3 clinical applications of pharmacogenomics. The first is using drugs to treat genetically inherited diseases. The second is risk assessment, which means using genetic information to determine the safety and efficacy of drugs in certain individuals. And the third is designing a drug regimen based on a patient's metabolic enzyme activity. In our project, we plan to focus on applications 2 and 3 in regard to medications commonly used to treat mental illness.
GeneSight is a pharmacogenomics test that analyzes your genetic makeup and how it might affect your response to drugs commonly prescribed for anxiety, depression, and other psychiatric conditions. GeneSight offers 2 versions of their test, a psychotropic test and an MTHFR test. GeneSight occurs in 3 simple steps. First, you collect a DNA sample from the inside of your cheek. This sample is then sent off to a lab to be analyzed. In about 2 days, your doctor will receive your results and can consult you regarding which medications will be best.
For our prototype, we decided to tackle our grand engineering challenge through legislation. With the help of pharmacy student Chelsea Weatherby and legal counsel Claire Standish, we drafted a mock proposal. Our bill has a few main points. First, it provides funding for further research into pharmacogenomics and the engineering of genetic-specific medications. Secondly, it incentivizes recommending genetic testing for all current drugs that can be tested for. Third, it protects the rights of patients who get a genetic test by invoking GINA, a Genetic Non-Discrimination Act that was passed in 2009. The bill also requires informed consent of a patient before they can agree to a genetic test, which basically means that a patient must be fully aware of a test before they can elect to take one. Finally, the bill provides testing coverage through Medicare and Medicaid. Since our prototype is not a tangible object, we decided to survey the public as a form of testing and getting feedback.
Our survey was designed to get a grasp of how people felt about genetic testing for drug personalization, as well as to get feedback on our bill proposal. We organized the survey as follows. First, we asked before questions to determine what people knew about the subject and how they felt about the topic of genetic testing. Then we provided information on pharmacogenomics to give context and better educate people who were unaware before. Afterwards, we provided brief summaries of the main points of our proposal and then asked them questions to gauge how the audience felt about the proposal. We spread the word in various ways. First, we used social media posts to spread our survey. Then we posted flyers across Athens and NC State campus. We sent out a STEM Academy email, and we directly asked friends and family to take the survey. Now we'll get into the results of our survey and discuss what we learned from it.
Our survey received 115 responses. A vast majority of those were 18 and under, almost 60%. This is shown here with a skewed right distribution. What's interesting of note, though, is that the ages ranged all the way from 16 to 81. In our medical questions, we asked beforehand to get a scope of the mental illness issues and to see if people had already been taking medications that fall under genetic testing availability. This part was completely optional because we wanted to make sure people were comfortable sharing their personal information. The important points here are that 53 respondents indicated having some form of anxiety, depression, or other mental disorder. 19 people indicated taking or having taken a drug that currently has a labeled biomarker, and surprisingly, only 5 people indicated that they have gotten a genetic test for any of these medications.
We then asked questions before and after respondents read our proposal. Before the proposal, respondents were split on support for genetic testing, and they weren't very well aware about how pharmacogenomics worked. Afterwards, people indicated a much greater level of understanding and roughly the same level of genetic support for genetic testing. Out of the 115 responses, overall, 87.3% indicated a strong level of support, a 4 or a 5. Only 13 respondents indicated a weaker level of support, and these respondents provided critical feedback as to why they gave such low marks. We will explore these further in the next section.
Our survey is not perfect. This is due to a lot of confounding variables that we noticed that may have affected how the data was distributed. We'll go through a few of these right now. The first is the age distribution. A large majority of the respondents were 18 or under, around 60% of them. The 40% of the older responses were also widely variable, ranging from 19 to 81. The high concentration of that younger influence may have positively skewed support in our favor. Because they're closest in age to us, they're more likely to see things from our perspective and thus more likely to support our proposal. However, 40% of those who indicated a strong level of support, which is like a 4 or 5, were above the age of 18. Second is the amount of information we could put on the survey. Obviously, we can't paste our entire bill with every detail into the survey. That'd be too much reading, and people would get bored or tired out easily. Thus, we were forced to condense and cut down large portions and summarize our main points of the proposal. This resulted in people having a lot of questions and concerns that could be answered with the more detailed approach that we weren't able to provide. This may have slightly skewed some negative support. Third is the population survey. Since we mainly put up posters and flyers and spread word through our campus and NC State's, this would have explained the age distribution that was provided in the first point. The important patterns and areas of concern that we got through our feedback was privacy, government involvement, and physician incentives. Privacy, people were concerned over how the information would be handled. Our answer is that the testing only focuses on one specific gene or enzyme, not your entire genetic code. So privacy, your information is less valuable to people who want to hack it. Government involvement is people wanted more private involvement rather than government funding and research. Our answer is that we thought it'd be easier for us to condense all funding and research through a centralized location. Getting involved in private legal loopholes is a little bit muddy. Third is physician incentives. People were concerned that there would be a lot of bias in medicine if we introduced incentives. Our answer is that we were stuck between mandating testing and providing it as an option. And we chose to provide it as an option, but with strong recommendations through incentives.
Hypothetically, if our bill was to be modified in Congress and passed, it would lay the groundwork for encouraging more genetic testing to be done. Physicians would be able to prescribe patients with more effective drugs that are tailored to them, reducing and even eliminating side effects. Thus, patients would not have to make as many return visits to the doctor, saving them money. On the research side of things, the more people that get tested, the more information we can have over how drugs are affected by our genes. Scientists will be able to recognize new patterns and identify new genomes that will affect the effectiveness of a drug. They may also be able to design new medicines that work even more efficiently. The long-term goal of pharmacogenomics is efficiency and good health. We hope that you have enjoyed our presentation on pharmacogenomics and engineering better medicines. Thank you for watching and have a wonderful day.